Welcome to the Researched RN podcast. I am your host, Steven Cuzmenco. In this podcast, I discuss new and interesting peer-reviewed research articles from various nursing researchers and other professional publications. In this third episode, I'll discuss an article published in the American Journal of Nursing titled Exploring Medication Safety Practices from the Nurse's Perspective. It's authored by Laura Arkin and colleagues. To start off with some background information, we know that one of the core tasks of all nurses is medication preparation and administration. Nurses' ability to safely administer medications is influenced by their individual approach to preparing and administering them, which is also influenced by the facility's medication system and the nurse's individual patient assignment. Medication administration takes a significant amount of cognitive effort because it requires the use of various information sources, including the physical assessment, vital signs, medication guidelines, and the patient's reported symptoms. And so nurses have to collect all of this information and then use their judgment and reasoning to determine if holding or modifying a medication order is appropriate, and then seek provider consultation. Studies have suggested that medication errors can range from 10 to 30%. Interventions aimed at making this process safer and more efficient can include double-checking medications, education and training, barcode medication administration, and medication safe zones, which help to minimize distractions or interruptions. But unfortunately, these interventions might be put in place with little to no input from the direct care nurses that are actually doing the work. And so even with all these safety precautions that I just listed that are put in place in many of today's hospitals and healthcare environments, medication errors continue to be a national issue. So there are few qualitative studies exploring nurses' experiences and perspectives on medication safety, especially studies looking at American nurses. So these researchers sought out to, quote, explore direct care nurses' experiences and perspectives on medication safety practices and errors, end quote. What these researchers did is, using semi-structured interviews, they conducted a descriptive qualitative study between March and November of 2019. Study participants were recruited using an existing list of volunteers from a prior study, and more were recruited through emails and hospital-level meetings. Nurses were eligible to participate in the study if they were an RN or LPN that administered medications on inpatient, acute care units, and in the ED. Nurses were excluded from the study if they worked in ambulatory, procedural, and outpatient settings, as well as nurses that worked in leadership, administration, education, and executive roles. They used open-ended questions that were developed by the research team. Some of these questions were, what's a typical day like on your unit when you prepare and give medications? Another one was, what gets in the way of safely administering medications? And a third question they asked was, when a medication error is made on the unit, how is it handled? There are many other examples of the questions they asked in the manuscript if you have a chance to read them. For the data analysis, the researchers utilized direct content analysis to examine the interview data and identify themes. And so getting into the results, the study included 21 nurses who participated, and the majority of nurses were female, non-Hispanic, white, with a mean age of 39 years. The age range of the study participants was 24 to 60 years old. The majority of the study participants had a bachelor's of science. The range of nursing practice was 1 year to 34 years. The four major themes that emerged from the interviews were as follows: the care environment, nurse competency, system influences, and the error paradigm. So let's start with the care environment. We know that hospitals are really busy, and individual units within those hospitals can be also busy or less busy. Distractions happen from many sources: patients, family members, other nurses, other departments calling, charting, the list goes on. Nurses must have the ability to focus on the task at hand, literally holding medications and metaphorically. So they're doing this while they're completing other tasks and also completing tasks that are time consuming, such as crushing medications. That may not be a problem for just one patient, but when you have to administer medications to 5 people and 3 out of the 5 have to have crushed meds, and you have to know which medications can or cannot be crushed, and you have a short window of time before the medication administration is considered late, well, now you have some distractions. This causes stress, and it's hard to think when you're stressed. And unfortunately, nurses in this study shared that when things got busy or they got stressed, they had the tendency to bypass systemic safety measures and make shortcuts. And so that is the care environment. Regarding nurse competency, this had to do with the knowledge and skill of nurses. This is influenced by their experience and their clinical judgment, which also comes from experience, and that takes time to develop. Newer nurses, we know, have a steep learning curve, and they must learn many skills in a short amount of time. And so the other thing that influenced clinical judgment was the assumption that orders would be the same, but we know that orders can change even in the same unit because they're based on the patient and the provider. And so it's important that nurses pay attention to orders, which was something that was mentioned in the interviews, that they may not always be paying attention to orders. Something else that came about from this regarding clinical judgment was that the concept that nurses are responsible to question orders and act as, quote, gatekeepers for patient safety. One of the things that helped was any real-time cues that could help them prepare or administer medication safely. One of the examples that was shared in the interviews was that a nurse said they had a dilution table that was attached to the automated medication dispenser, and they used that as a safety check prior to administration because they were newer. And so that's nurse competency. With system influences, this has to do with hospital policies and procedures. Some of the procedures mentioned in the interviews were helpful and some were not. Some of the helpful ones were requiring a double check for high-risk medications and also having a pharmacist available to consult. Some of the hospital policies and procedures that were not helpful were the EHR limitations or incorrect orders that were included in the EHR. Other non-helpful aspects of the system included technical issues with the medication dispenser, any logistical issues that had to do with restocking medications in a timely manner, and then also where the medications were restocked. One of the participants said they had to look in 3 different places to know if the medication had arrived prior to administering it. And then lastly, poor provider communication was a systemic influence that negatively impacted safe medication administration because they had to wait for a reply, let's say for a medication that was for electrolyte replacement or had to do with any blood tests or diagnostics. The timing of procedures and treatments was also a negative influence. And so the idea that if you have to prepare a patient for a surgery or a dialysis treatment, for example, which medications do you hold? There might be some that you do or don't. And so if there's any delay in communicating from the provider or to the provider on which medications to give, that can not only delay medications, but also make it harder to know which ones you need to give. And that is systemic influences. With the error paradigm, this is influenced by all 3 of the previously mentioned themes. And this is the 4th and final theme. This has to do with how nurses think and feel about their actions or thought process regarding the error or a near miss. Nurses found to have maybe not recognized the severity of an error. Hearing about errors, even if it wasn't their own or the department they worked in, made them more aware of their own practice. And that led some to read orders more thoroughly. Others downplayed errors, and some didn't report errors they made, thinking that they were accepted and part of the job and unavoidable. And so unit culture really influenced this. The example given was crushing medications that weren't supposed to be crushed, but knowing that the rest of the unit does it. So is that really an error because no one else is calling me out on it? And so I'm just going to go on with the broader crowd. Others express thoughts that an error was fine or permissible if the harm wasn't severe. An interesting observation that was noted by the researchers is that as the interview went on, the definition of medication errors became more ambiguous, because as they shared, they felt that, well, maybe that wasn't an error because nothing really bad happened, or no one really called me out on it. So nurses ended up having their own definition of an error that was based on their self-perception of its severity. And so the concept of a benign error was generally accepted by the participants, and so some did not view that as an error that required reporting. And so moving on to the discussion, we found that the care environment was one of the major themes. This has to do with distractions that can lead to medication errors. And the sources of distractions varies, but ironically, it was shared that fellow nurses and other clinical team members were frequently the source of distractions that led to medication errors or near misses. But also, other aspects of the care environment included high patient acuity and inadequate staffing if there wasn't enough help. With nurse competency, new nurses must learn quickly, and unfortunately, that is the reality of the nursing profession today. And they must be able to perform their newly learned skills in a chaotic environment. And so ongoing training and education and mentorship can help. Even for experienced nurses that lack this training, they can deviate from safe medication practices. With system influences, these include, again, policies, procedures, the available resources, such as a pharmacist, medication availability, and the stocking practices, the timing of when medications are restocked, where the medications are restocked, unclear physician orders, or any logistical communication issues. And so poorly designed workspaces also impacted whether or not a given location was considered a safe zone where medications could be prepared without distractions or with minimal distractions. And lastly, the error paradigm is how nurses perceive or think about medication errors. And this is where things got ambiguous as the interview went on. So errors are influenced by nurses' beliefs and experiences. One of the examples was a missed dose or giving a second dose of a medication too soon, such as Tylenol. Maybe it's just Tylenol. It's not really going to hurt them. Is that really an error if I did that? And so the definition of a medication error became unclear and was unclear for some or brushed off by others. That was fueled by complacency, a casual attitude, the thought of it's just part of the job, and the overall unit culture. And this greatly impacts the reporting of medication errors. The study strengths and limitations, there were some. Nurses in the sample were from a select number of hospitals within a single healthcare system. And so we really don't know how well these themes can be attributed to nurses across the country because it looked at only a small number of nurses. Participants were also self-selected volunteers, and so it's possible that the sample that actually participated was more conscious of their medication practice in a way that they were willing and able to verbalize it than those who did not participate in the study. With the implications for practice, so this is a big one, and I had a really good time reading this article because it really helped me see how I need to be constantly supporting medication safety. You know, it's more than just, hey, here's a quick blitz of education, or here's a helpful flyer, or here's how you access this. It really does need to be a structured approach to training and ongoing training and competency. Hospitals must work to make the care environment less chaotic. This includes noise levels, locations of medication rooms, the makeup of the medication room, where things are laid out, and how medications are supplied by the pharmacy. So hospitals need to make sure that this is happening smoothly. And then, of course, hospitals need to make sure that there's adequate staffing so that the workload of nurses can be controlled or minimized in a way that supports safe medication practices. Educational strategies was a big one. education must be implemented that helps nurses learn how to maintain focus and prioritize tasks so that on a daily basis, they are minimizing distractions or disruptions that can influence safe administration of meds. Education and training should also include the available resources that nurses have. So this could mean the online databases, the location and how to access the most current policies and procedure guidelines for medication preparation, and then whether or not they have pharmacists available for consultation, how to contact the pharmacist, what is it that the pharmacist can help them do. These are things that are really important that educators inform their nurses that they have. And a third major implication for practice that was mentioned was that healthcare organizations really should encourage active participation in medication safety committees on behalf of the direct care nurses. And when safety initiatives are being worked on prior to implementation, they should include and connect with the direct care nurses so that they're not implementing safety policies that aren't feasible or reflective of real-world practice. And lastly, building a workplace culture that encourages error reporting without fear of retribution is something that hospital leaders should strongly consider. And so finishing up this third episode, the things that I really got from this article was that nurses' perspective on medication errors really should be well defined. Nurses need to know this is a medication error, this is how I report it, and also this is why I should report it. Hopefully you work in a place that nurses are not immediately punished for reporting errors, because we know this may negatively impact whether or not they willingly report that medication error. If you feel like you're in a place that would punish you for reporting, then I can see why medication errors aren't reported often or well. So I really encourage you to read this article. There are many other things that I wasn't able to discuss. This is just a general summary. If you have any other article that you'd like for me to discuss, or you'd like to give any feedback to the show, you can email me at researchedrnpodcast@gmail.com. And so thanks for listening, and hope you tune in for the next episode.